Hi, everyone. Welcome. My name is Hyen. I'm the nurse manager for Outreach Education. So welcome to this month's Nursing Grand Rounds presentation, and we present these 1-hour professional development opportunities each month on the first Thursday from noon to 1 p.m. Just save the date for the next Nursing Grand Rounds, which will be on June 6th, I believe, on ventilators and nursing care. And we invite you to attend live via Seattle Children's main campus or remotely via WebEx. So please be sure to sign in at the front desk or wherever you are by logging in with your full email address and your name. And instructions for obtaining CEs are on the course flyer that we've distributed. Just a few reminders about engagement. This is a live event that's also being videotaped, both speakers and audience, and we want to make sure that these talks are as interactive as possible. And we invite you all to ask questions. For WebEx participants, you are welcome to type in a question using your chat function, and we will ask the speakers at the end of the presentation. So following today's presentation, we will send you a link to the post-course survey where you'll be able to print a CE certificate after completion of the post-course evaluation. For site coordinators, please send us your sign-in sheets to get CE credits as well. So to start today's presentation, we have Bailey Brinks and Kayana Kiefkas. Bailey is a nurse at the Seattle Children's Prenatal Diagnosis and Treatment Clinic. She obtained her BSN from Grand Valley State University, and prior to moving to Seattle, she was a pediatric and neonatal nurse in Michigan, and she was a NICU nurse at the UW Medical Center, then joined Seattle Children's Prenatal Team in 2016. And Kayana is the genetic counselor at the Prenatal Diagnosis and Treatment Clinic as well. She earned her master's degree at the University of Utah in genetic counseling, and prior to joining Children's, Kayana worked at the Yakima Valley Memorial Hospital, and the opportunity to focus on prenatal and pediatric genetics brought her to Seattle Children's. And she has worked there for the previous 6 years, and her interests include the evolving role of the genetic counselor in healthcare. So part of today's regional neonatal nursing grand rounds, we wanted to present on this topic just so you are kind of aware of the mental state of mind and what parents are have knowledge of prior to getting admitted into our NICUs or any of the NICUs, the background information that they already have to kind of understand where they're coming from, what knowledge they already have to better serve them when they get here. So please welcome Bailey and Kayana.
I guess I didn't ask you how to switch slides. Can I just? Oh, okay. Well, thank you all for coming. My name's Bailey, and as Hyen said, I am the nurse coordinator in our clinic, and Kayana will be speaking a little bit later about some genetic testing prenatally. So to start, we have no conflicts of interest. And then here are our objectives. So I'm going to describe the role of our clinic, resources that we provide families, how to contact us and where we're located. Most people don't even know we exist. And then how to find a mom's chart. So if you are taking care of a baby after they're born, finding their charts and any genetic testing. And then Kayana will go more into prenatal genetic testing. So first question we had was, does anybody who knows that we even exist, or is anyone knew about us before coming that there was a prenatal clinic? All right, so a few people. Most people are surprised that there is a prenatal clinic and that we are one of the only clinics here at Seattle Children's that takes care of adult patients. And so that's why we're gonna go over that. So our clinic is a multidisciplinary clinic that brings together obstetric care with pediatric specialty care for families when a pregnancy is complicated by a known or suspected condition in the developing fetus. And so they come to us. We do special diagnostic testing and consultations. So we do majority of fetal echoes, we do ultrasounds, we do fetal MRI, genetic counseling and testing, and we offer low-dose CTs. And then there are fetal interventions that are available if necessary. So for fetal cardiac arrhythmias, we can give medications. There are fetal bladder taps and shunts. We do exit procedures for airway management, and there are fetal surgeries being offered around the country. We don't do any yet, probably to come, but we don't do any yet, but that is something else that we can refer out for. And then all of this information is used to counsel the families on kind of what to expect for their child after birth, so they can make the best decisions early in the pregnancy about kind of their child's care starting prenatally and postnatal. And then we also make plans with families and OB providers to discuss delivery planning. So where should a baby deliver, and what should we expect after birth? And then we do screening echoes, so not everyone that comes into our clinic is coming in with a suspected condition. So we do screening echoes, and then our referring providers, our maternal fetal medicine or high-risk OB providers around the area, primary OBs, midwives, and sometimes self-referrals, but for the entire WWAMI region. And then our goals for our clinic, our overarching goal is to improve outcomes related to, but not limited to, family logistics and support. So hopefully we free up some emotional energy so that parents can focus on their baby when they're here, and put potentially less burden on the staff and the resources once a baby is born here at Children's. Because families will have time to work some of this out ahead of time. So say they have a 2-year-old and they now need to deliver in Seattle. What are they going to do with this 2-year-old while they have a baby that needs to be in the hospital for several months? Most of our families have to come to Seattle prior to delivery if they don't live locally, and trying to kind of work out some of those logistics, jobs. If they have pets, how are they going to pay their rent, and just try to get some of that stuff worked out ahead of time. Emotional preparedness, so families kind of start beginning that grieving process of a normal pregnancy and a normal baby, and kind of they're able to better prepare and engage in their baby's care if they've already kind of started some of this grief process. And then we also hope that possibly couples are better aligned going into delivery and what to expect after their babies arrived, and had some communication on their wishes and hopes for their child, and hopefully are better aligned there. Healthier outcomes. So sometimes our families come in expecting to do a home birth, and unfortunately we have to tell them that that's not the best place to deliver. They were going to deliver at a facility that had no NICU. So we're able to kind of intervene ahead of time so a baby's delivered in a safe location, and we can get them the care they need before they get really sick if it wasn't necessarily picked up prenatally. We do, depending on the case and the severity, talk about neonatal palliative care. And if this is an option for a family, we can start that early. We can get some of that logistics planning in place and allow families to have that quality bonding time with their baby before their baby was just rushed away to Seattle Children's. They're left wherever they delivered and separated from their baby, and not actually getting to have quality time spent with their baby if the interventions were not necessarily going to have any benefit. And then we also start discharge planning. So we talk about primary care providers, that they still need a pediatrician, starting that. We talk about car seats. We also talk about logistics. Again, some of our single ventricle families have to stay in the area for 6 months after leaving the hospital for their first admission. And that's a huge, just uprooting their entire family. So starting some of those discussions and what are these families going to do. So that are some of our goals. And then this is where we're located. So we are in the Springbrook building. So we're above Adolescent Clinic. If anyone's ever been over to Adolescent Clinic, we're on the 3rd floor right above them. And then we have multiple phone numbers. So we just listed them here just in case you ever needed to contact us. We'll have them again at the end if anyone wanted to write those down. And then we do have our regional sites. So some of our cardiology patients are seen Bellevue, Everett, Wenatchee, kind of the Tri-Cities, and then our South Sound group sees some of our fetal echoes, and then we also, urology, I'm trying to think, we have urology, sees patients regionally, and then craniofacial sees patients here on campus, but I'm trying to think, is there any other regional? Alaska sees some of our prenatal as well, so. And then our core team, so we're a small team, but all of the providers or the pediatric specialists come into our clinic on their scheduled days. But the ones of us that live there, we have 2 family service coordinators or FSCs. We have 1 program coordinator. I'm one of the nurses. I work 4 days a week, and then we have a per diem nurse. We have a nurse practitioner who's also our clinic manager. We have Kiana, who's our genetic counselor, and we have a social worker there who's not full-time, but she's there a couple days a week as well. So small team, a little cozy office. And these are some examples of the providers that come into our office to provide care. So we have scheduled providers or templated providers, and then we also have non-templated providers. So majority of what we see is cardiology. We have cardiology about 4 days a week, so we don't see patients on Wednesdays, but about 4 days a week. We have fetal echoes. Maternal fetal medicine from the University of Washington comes over 2 days a week to see families. And then we have general surgery comes in, we have neurodevelopmental and neurology, our fetal MRIs, and then nephrology and urology. As needed, we will bring in genetics, cardiac surgery, ENT, neurosurgery, craniofacial, and orthopedics, and really any other specialty you can think of. We may have brought them in at one point, depending on the diagnosis. We kind of have to triage that with each case. I'm trying to think, is there anybody else? No? Okay, so those are most of our providers. And then just to give you a sense for kind of how much we see of different specialties, the majority of what we do is cardiology. And that's about, these are based on our numbers from last year, about 80 to 85% of the patients we see, their referrals are cardiology driven, so coming in for a fetal echo. And then neurodevelopmental and surgery are about the same at about 7%, and that's just because of how they're templated. We are templated to see each of those specialties for about 2 to 3 patients a week, and so that kind of keeps us held at those numbers. And then other, that includes urology, nephrology, ENT, craniofacial, and some skeletal anomalies, and that's about 7% again of what we see. And then MFM, or our UW providers, they see about 24% of these patients in our clinic, since our clinic does combination visits. And then genetic counseling, about 5% of these patients last year had genetic counseling with us because they came from a site that didn't offer that service, or they needed additional counseling, which kind of can go more into when she talks about that. And then, let's see here. So our clinic flow and kind of how our clinic works. So we receive all of our own referrals. So our referrals do not go in. Sometimes they do, but they're not supposed to go into the normal clinical intake referral where the rest of the referrals come into. So we have our own fax number. We have our own referral form that we use, which is different than the main hospital. So everything comes into us, and our FSCs process the referrals. And then every referral is triaged and reviewed by one of the clinical staff. So me, our nurse manager, or Kiana will review all of the referrals to make sure the appointments being requested by the outside provider is correct for the diagnosis, that the timing's correct, and that nothing else really needs to get added. And we also make sure we have the right records for the patients. And then our FSCs go ahead and schedule. So we don't use the call center or any of centralized scheduling at all. We do all of that on our own. And then if noted during that triaging process that a family needs to relocate or has resource needs, one of the clinical staff or our social worker will call a family prior to appointments to try to coordinate that and try to help with whatever relocation or assistance they need prior to even coming to their first visit. This is really common for our Alaska, Montana, and families coming for relocation at 36 weeks in their pregnancy. It's the first time we've met them, and they need a lot of help to get here. So we kind of start that process early. And then these are some examples of some referrals we might get. We kind of divided them out for fetal indications versus maternal. So you guys can just kind of get a sense for what we're seeing. So structural anomalies, chromosome, fetal arrhythmias, an OB can't clear a fetus's heart on their normal ultrasound a couple times. Then they come into us for further screening and increased NT high drops. And then if a family had a prior child with heart disease, maternal heart disease, diabetes, lupus, medication exposures, viral illnesses, and a lot of other reasons, but these are just kind of a broad sense for referrals coming in and what those might look like. And then during the visit, so we assign one of the clinical staff members, or we like to say clinical liaison, a patient, and we follow a patient throughout their pregnancy. So that means that we will do a chart prep on a patient. We will prepare kind of a face sheet or a Cardex. I don't know what you guys use in your practice, but to kind of make sure that the doctors have all the information prior to them even coming into our clinic. So who's ever assigned that patient will kind of do all of that preparation, and then they are usually the ones who also check in the patient during the check-in time to review all of that information to make sure we didn't miss anything and to prepare them for what their day is going to look like. And then a patient will start their diagnostic testing, whether that's just an echo, whether that's an echo and an ultrasound. Sometimes it's echo, ultrasound, MRI, lots of different things. And then after all of their testing, we have a consultation. And that consultation usually happens with multiple providers in the room if that's the type of diagnosis. So if it's cardiology but also needs the high-risk OB, we try to bring everybody into the room together to have kind of like a care conference or a multidisciplinary discussion with the family about kind of next steps and what to expect. So we go into diagnosis, prognosis, kind of what it's going to look like throughout the child's life. So starting from delivery up until, I guess, adulthood, we'll go into what that's going to look like for them. And then we talk about management options. We offer emotional logistics support, and then we, if necessary, talk about palliative care. And then as the nursing staff or the clinical member taking care of them, we sit in during those consults typically, and we take notes for the family, and then we put those in a clinic visit summary and send them home with that at the end of the day. So our clinic visit summaries are quite lengthy if you ever look at them compared to other clinics, just because we do put a lot of detailed information in there about what the providers talked about. It includes what the rest of their pregnancy care is going to look like, what their follow-up appointments with us will look like, and then any other pieces of important information, and then we'll help coordinate any follow-up appointments that are necessary. So some of our days, it doesn't look like we have a ton of patients in clinic, but some of our patients can be there from 2 to 5 hours or longer, kind of depending on what the case is and what's going on and how many providers they are seeing. Like our 8 o'clock patients are still there right now. So resources that we provide families, so we give them, like I mentioned, a lot of education material. We do have standardized clinic visit summaries, so if you are in and out, like a regional site that does see fetal patients, and you need access to those or you don't know how to find them, you can always reach out to me. I can tell you how to find them in CIS so that you're not like creating the wheel. We have all of those kind of already created for some of our standard diagnoses, and that's pretty easy. Depending on if they are coming to Seattle Children's Hospital after birth, we give them a packet of resources, of written material about different resources in the hospital, and we go over that with them, and then we give them other handouts based on the diagnosis if necessary. And then, let's see, that's the packets. And then in addition to all of the written material that we hand them, if they're expecting a neonatal admission, we used to do individual tours, but this last year we now do group tours. So our families are offered tours of the hospital about once a month. We have about, 5 to 10 families that come and join us. It's a 2-hour tour, and we have people come in. Lactation will come in, Child Life comes in, our transport team joins us, social work joins us, and they present to the families the services they can offer while they're here. So hopefully families know all the services, kind of have a sense for that, so while they're here they don't have to try to be figuring that out, and they can really just spend time with their child. And then after we have the discussion, we go walk through the hospital. So we go to the Family Resource Center, we go to the CICU or NICU based on where that family needs to go. We go look at the surgical floors, and if there's other little ones, we'll go look at the playroom and the pool. And then we also offer families counseling resources in the area, whether that's grief counseling, marriage counseling, decision-making counseling, or crisis counseling. There's lots of different counseling that these families can benefit from. So we also offer that as a service, or I guess we just provide them the phone numbers to call. And then after the visits, we call referring providers. We let them know what we found, if it was the same or different from what they referred in, and what the plan of care is moving forward so that everybody is on the same page. So either the clinical staff or the physicians will call the referring provider to update them. Like I've mentioned, we assist with relocation. We help coordinate any follow-up appointments with us. We also help coordinate appointments with the University of Washington. If a family qualifies, there are some prenatal research studies as well that are going on, so we will help coordinate those, and we offer and we consent families for that. Then we continue to offer support and education. Families go home with our phone number and emails, so we can continue that process so they don't have to wait till the next visit to ask us questions. And then we assist with delivery planning. And then we have the all-famous forecast list, which I don't know if any of you have seen, but that's really to help us, everyone here at Seattle Children's prepare for deliveries, and our outside hospitals also prepare for upcoming deliveries. And then the other piece I wanted to go over was how to find a prenatal chart. So if you're taking care of a baby and you know that they had a prenatal diagnosis, and you're wondering, well, what was the plan? Did they have genetic testing? What was this family? What have they already been told? Moms have their own MRN here. So although they're an adult patient, they get their own MRN and they are a patient in CIS. So you can always look up, you can just ask the mom her name and date of birth, and you can look up that information, and all of that, all of her diagnostic testing, prenatal records, care coordination, everything is there. If postnatal genetic testing was done, that should actually be in the baby's chart because that was done on the baby after the baby was born. But if there was an amniocentesis or any other genetic testing or cell-free DNA, which Kayana will go into, that will all be in mom's chart because that was technically done on the mother. So if you guys are looking for that, it is there, and maybe it might help you know kind of, just like Hayan said, their knowledge or the information that was provided to them before they came in, because a lot of them go through shock, and it doesn't matter how much we can tell them prenatally. That kind of all goes out the window sometime when baby's born, but hopefully some of it's stuck, and you can just kind of remember when they talked about this, and you can see all of that. You can see the clinic visit summaries and everything that we kind of told them and tried to prepare them for. So I think that's kind of our very broad overview quickly of our clinic and what we do and kind of how we function and what we offer family as resources. And I know Kayana is going to go more in depth into some genetic testing that we can do prenatally and things like that.
All right. Just going to put this in my pocket. All right, so I'm going to talk a little bit about genetic counseling and testing that happens during pregnancy. My idea for today and the topic that I chose around testing during pregnancy, I know this team won't be orchestrating that testing, but I wanted to give you a basic background because you're often doing and picking up the pieces from the pregnancy, and it's helpful to understand when a family has completed testing all the way through diagnosis versus a family that has stopped at some screening. And testing has gotten more complicated in the last few years, and it's complicated for families, it's complicated for providers, and I thought if I gave you some background, you could maybe understand where the next spot to go back to, or maybe where a family is in that, and if they need some further steps. So I'm just going to go over some background, run through screening, maternal serum screening and cell-free DNA, go through diagnostic testing, and then just an overall understanding. So I wanted to start with the definition of genetic counseling, and I think this is really important to walk through and have an idea of what we're working with and trying to achieve with families. Some of the big points that we make, we do interpretation of families and medical histories to talk about what's occurred, if it could happen again. Education is very important. That's where coming and knowing these tests inside and out is essential. But the last part, counseling to promote informed choices and adaptation to the risk or the condition, I think is where we really partner with our nursing team and our other teams, because adapting to this new information is really where families are. And we start the process of learning that. We're in the first couple of steps of their journey, and then we hand them over, and our families are still in that adaptive process. The other part is promoting informed choices, and that's what we try and do by having this education and information, is help our families, whatever their choice is, to be informed about it, whatever test they choose or choose not to do, being able to say, this is why I chose that, and this is why, and be comfortable with that, and know the pros and cons. So my favorite analogy is that chromosomes are like books, and you have a double set, one from mom, one from dad. And so when you have a big chromosome anomaly, it's like you have a whole extra book or you have a missing book. And we'll talk a little bit about microdeletions and microduplications. And I think of those as like having a few extra pages or missing pages. And when we're talking about single gene disorders, that's a spelling error on the page. And so I feel like that's a visual most people can understand and walk along with. And so I'll come back to that analogy as we walk through to hopefully help you kind of quickly have a general sense of what we're talking about. So this is the briefest of brief explanations of some of the conditions we're going through. Families get a much more thorough, nuanced talk, but trisomy 21 or Down syndrome, kiddos have hypotonia, mild to moderate intellectual disability, and a variety of birth defects, including about 50% have a heart defect. Trisomy 18 or Edwards syndrome, babies have slow growth, heart defects, intellectual disability, and multiple congenital anomalies. Trisomy 13 is very similar, also with heart defects, brain and spinal cord abnormalities, and smaller, poorly developed eyes. For trisomy 13 and trisomy 18, 5 to 10% of those children live past their first year. A good example of the microdeletions and duplications that people may know is 22q deletion. And so children and individuals with that condition often have heart defects and mild to moderate intellectual disability, cleft palate, low calcium, and many other things can go along. But like I said, brief description so you have a general sense of what we're going over. So our recommendations during pregnancy is that all women should be offered screening and diagnostic testing. There's a wide variety of options, and no one screening method is superior to others. And there's pros and cons, and that's some of the things we go through. And I think understanding that this process has continued to become more complex for patients as well as providers is really important. It's really difficult to stay on top of this information and to have everybody understanding the nuance of it. So it's been a big process as more tests have been offered. This has been the recommendations for all women being offered for many years, but it's become more complicated. So just an idea of the timeline. So most of our testing happens between the first and the second trimester. We start with the screening options, and there's a variety of different tests and different names for them. Some span and have 2 blood draws, maybe an ultrasound. Others just have 1 blood draw. This is the ultrasound that goes along with some of these tests. Anatomy scan, cell-free screening can happen around here. And that our diagnostic testing, CVS happens earlier, amnio happens later. So just knowing that it's very heavily weighted in this first part of pregnancy. All right, so screening. Basically what we're taking is a large group of people and trying to identify those that likely have a finding. or do have the condition. And so we're trying to be highly sensitive. We want to not miss anybody that's affected. And so we're okay with our screening test of having a few people that we say, oh, you're at increased risk. And when we do diagnostic testing, we're like, actually, that's not what happened. Because that's our goal, is to take this large group of people and narrow down who we really need to concentrate on. Once there's a suspicion, that's when diagnostic testing comes into play. So serum screening quickly really just looks at proteins or analytes produced by the fetus and the placenta, and that are in mom's bloodstream. We chart those out by multiples of the mean, and know that helps us quickly know if an analyte is too high or too low. And we compare various factors because they can alter our interpretation. Age, ethnicity, gestational age, diabetes. When I first started, I'd see a lot of women and talk with them and say, oh, you're at increased risk for Down syndrome. We're going to do an ultrasound. Do you want an amnio? And talk with them. And we get them into ultrasound and find out, oh, you're actually not where we thought you were in pregnancy. So no wonder your analytes look like they did. Actually, now that I know where you are, let's call the lab. And you'd call the lab, and we'd readjust, and we'd be like, suddenly you're not at increased risk. So that would happen a lot. So all of these factors are really important. People get their results in 1 in blank. So 1 in 10,000, 1 in 100, 1 in 300. So again, it's emphasizing this is a chance, not a certainty. We screen for neural tube defects, trisomy 21, trisomy 18, trisomy 13. But the cool thing about serum screening, it also tells us about how the placenta is functioning. Do we need to watch that a little bit more? Picks up additional conditions, X-linked ichthyosis, Smith-Lemli-Opitz. We know from looking at these analytes, from studying these over many, many decades, that it gives us a little bit more information. And so that's one of the neat things, and continues to be the neat thing about serum screening. Here is just some examples of the analytes and how they look. So the first is a normal pregnancy, and you can see the ebb and flow, and now you know why we do multiples of the means, because knowing these exact numbers would be really hard. But we can see the patterns. So a baby with Down syndrome will see an increase in HCG and DIA, so the blue and the purple, and a decrease in the pink and the UE3. And then babies with trisomy 18 have a decrease across the board of those analytes. So there's specific patterns, and how they look affects our interpretation. So now I'll move on to our newest screening method, and talk a bit more about that. So cell-free DNA, the entire fetal genome is represented in the maternal plasma and can be detected as early as 7 weeks. And this cell-free DNA is rapidly gone. Within 2 hours after mom gives birth, there's just not in her system. And a really important thing to understand as we talk about these things, moms have cell-free DNA. All of us have cell-free DNA. We have cells that apoptose, break up. We have this free-floating DNA in our system. Moms versus fetuses are of different sizes. You can see that they're 20 base pairs different, and that is what has made this technology possible, is this difference, and has made all the difference in us being able to sort them out. So most of the DNA floating around, and you can see the cute little free-floating DNA versus those in the cell, is coming from the mom, but about 10% is coming from the placenta. And I think that's a really important part, because it's called cell-free fetal DNA often, but its contributor is the placenta. And placentas don't always match babies, and babies don't always match placentas. And so that is a limiting factor for this testing, and why sometimes we have a test result that comes back one way, and we do diagnostic testing, it comes back another. So like I said, we're just going to flow through. So basically, we extract and prepare the cell-free DNA, and then we do next generation sequencing. So I think of cell-free DNA as like beautiful lines of prose from these books, right, floating around in your bloodstream. And I think that's a really beautiful thought. So we take that and we do sequencing where we can read this prose from all of these books all at the same time and get a sense for them and what they are. And then we take those sequences and we match them up. And we say, oh, what goes here, what goes there? And they're unique sequences. So when I was doing this, I was thinking, of like, oh, Romeo, Romeo, wherefore art thou, Romeo? We know what story that comes from. And so we can see the alignment. We can see them align over each other and where that belongs. Another line would be like, a plague on your houses. They've made worm meat of me. Yep, same story. But if you say something like, it was the best of times, it was the worst of times, whoa, whole different story. So it's a unique identifier that belongs in a different spot, in a different bin. So we take these unique alignments and we basically do counting and we say, okay, where does this line up? The blue is the moms, the gold is the babies, we know their size different, and we say, are we getting about the right amount? It's all about amounts and putting them in what we call bins. When we have a baby with too much or too little, we get a difference. And so we can see clearly this baby has too much, and a result would come back saying increased risk for Down syndrome. Okay? Now, most results are coming back at this time as 5 bins, and those are the conditions I reviewed, trisomy 13, 18, 21, and then our sex chromosomes. But those aren't the only chromosomes we have or the chromosome conditions there are. So some people still, and families will say, oh, well, we tested for everything. And when you look back at their screening test, this is what was reported and this is what the test was ordered for. So it's actually not looking at everything. But we're getting more complicated and getting tinier bins and bins for more chromosomes and bins breaking up and lining up so we can get smaller and smaller and better understand and hopefully better detect early on smaller deletions and duplications, and maybe even single gene disorders someday as we especially look for kids who have a sporadic condition. So something that neither parents had pops up. It's not going to be in mom's DNA. It would be in babies. So again, cell-free DNA tells us about gains and losses of DNA, and it tells us about quantity but not structure. Remember, all of this is just free-floating. We pull it together, but we're not seeing how it lines up. The computer is lining it up, but it's not how it's actually lined up. And so that's another part that's important about diagnostic testing. While a lot of labs are saying, and one of the things we're hoping to continue to achieve is micro deletions and duplications, we'll miss about 20% at this time. And those are the ones that are detectable by diagnostic testing, and it's because of bin size. The cell-free DNA we can see down to about 5 megabases, and many microdeletions and duplications are less than that. So 22q deletion is about 2.5. So below that threshold, and that's in part why it's often missed, even though it's one that these companies are really, really trying hard to find and acknowledge. It's just a struggle because it is smaller than what we can find at this time. So I wanted to pull up this comparison of detection rates for serum screening versus cell-free DNA. And you can see in the top portion, cell-free DNA has a bit more detection rate, a bit higher detection rate than cell-free DNA, or cell-free has a higher than serum screening. But when we get down here in this other category, that's where kind of the surprise comes from, because I just talked with you about all these microdeletions and duplications and all these other fancy disorders, but it's lower than our serum screen. And that's in part because in some ways our serum screen is nonspecific. And what it's done for us is we do get a sense, oh, this placenta's not looking as well, oh, this came back with this increased risk. Things will come back, okay, increased risk of Down syndrome, we'll do the testing. Oh, trisomy 16, oh, 22q deletion. Because families were able to go on and do diagnostic testing, this alerted us. because cell-free in some ways is so specific, it's not able to alert us to some of these things. So you can see a huge difference right there in what we're picking up. So these are both very good screening tests. I put up here that maternal blood is used, and I think this is important because one of the questions I'll ask people is like, did you have screening? And usually use Down syndrome as an example because that's something people know, people can relate to. Yes, okay, you had testing. Did you have testing in your belly or did you have testing in your blood? And that can kind of sort out for you. Did they have a screening test or a diagnostic test? So a child that had a screening test that suggested a likely diagnosis will need diagnostic testing later. Even if the family didn't pursue that in pregnancy, that's one of the things that really closes the loop and is important. So diagnostic testing prenatally. So this diagnostic testing is to establish the presence of the condition. It can be invasive, but this is justifiable based on the need to establish the diagnosis. And we want it to be highly specific and there to be true negatives and true positives. All right, so we have chorionic villus sampling, so we can do that transabdominally or transcervically, and between 11 to 14 weeks, we go in and we get a small sample of the placenta. So that's another important point. It is a part of the placenta, so most of the time matches the baby, not always. And the loss rate is about 0.1 to 1.1% after a mom has had this testing. Amniocentesis done after 15 weeks, we have a loss rate of about 0.2 to 0.4%, done transabdominally. Both of these tests we do with ultrasound monitoring at the time. We know exactly where we're looking, we know exactly where the baby is, and the risks are overall relatively low. So what do we do with that fluid or that placental tissue that we get? We send it to the lab and we start our testing. So the preliminary testing we can get back, because you've just had a test, you've had something that indicates something's going on, you probably want a little bit of information back quickly. So again, those chromosomes we've looked at before, 13, 18, 21, XY, we can do what's called a FISH. And I think of FISH as like bright magnets. We can take the cells and within 24 to 72 hours, we can put those on, have them look. You can see these bright little spots is how it would look under the microscope, and we can count. Okay, 2 of those, 3 of those, and you can get a good general sense, and it tells us a little bit more about what direction to go. It also gives the family a little bit of information quickly. We can also do a low resolution karyotype, so chromosomes, this is what we're talking about, looking like. But it's early on, they haven't fully unraveled to as big and beautiful as we like them to be. So again, it's a preliminary result. So we rely on our final tests. So we want to do a karyotype, and so we get a big picture look. And again, this goes back to books. Do you have a whole extra book or missing book? And so here we have an extra book. Resolution is down to about 5 to 10 megabases. Another possible final result we can go for is a microarray. And basically, again, this is looking to see if we have extra pages, missing pages. We get results back that are pathogenic. Results back, yep, didn't find anything, everything's fine at this level of testing. And then we get variants of uncertain significance. So it's a little higher resolution, and we, again, are not able to know the structure. This is another method that, again, is using a computer to line things up, so we're not getting that nice structural picture, and that's what we're talking about in knowing the structure. You know how things are lined up, stacked, where they place themselves. But you get a good enough idea and a closer look, and sometimes that's what you want. Most of the time, the structures of the chromosomes are okay, and so most of the time, the microarray is fine. So I have a couple of examples. So a mother had serum screening testing, showed an increased risk for Down syndrome. She then, from there, did not want to do an amniocentesis, and so she said, well, I'll get a little bit of information, and so did a screening test, cell-free. So one screening test to another screening test, and the cell-free was normal. So goes on, has the baby, and the baby has features of Down syndrome. So what do we do next? Diagnostic testing. And so we did our quick FISH test, and it came back showing 3 signals. So 1, 2, 3 of chromosome 21. So baby has Down syndrome. But we always wait on the final results because it can tell us a little bit more information. And it did. So this is where, again, structure becomes important. So instead of having 3 copies of trisomy 21 free floating, the bottom of a 21 is attached to another 21. So she had, in most of her cells, 1, 2, 3 attached to each other, okay? However, in a few of her cells, she had 2 of this type. So she actually had 5 copies. So it could look like this. 1, 2, 3, 1, 2, 3, 4, 5. So Down syndrome, but another reason why we go on and do diagnostic testing. She had features, we had a clue that she had it prenatally, but this is one of the reasons why we go on. This is important information for us to have. This tells us we need to test the parents. This tells us we need to look a little closer. May need to do a little extra blood screening for her, these types of things. So another case that I had, a mom came in for a cardiac defect and brain findings, and she had cell-free testing from one of the labs, more bins, littler bins, and so what came back was a loss on the top of the 18th chromosome. And so this is associated with hearing loss, heart defects, seizures, cataracts, delays, and intellectual disability. And I called the lab, and I said, okay, just want to review this report with you. And she goes, I'm glad you did, because there's a little bit more information for you. Below our threshold of what we can report, there's also a little piece missing on the bottom of chromosome 18. And so I can't report that, but what it tells me, and what we'll see if it comes out, is that there may be a ring of one of the chromosome 18s. So instead of it just missing a little piece at the top, this is missing a piece on the top, piece on the bottom, and it's stuck together. And this adds to the prognosis, makes the prognosis even more significant. So it was nice to be able to tell the patient, again, I don't have confirmation you didn't do diagnostic testing, but I have a clue this might be what's happening. So if you want additional information, we may need to proceed. And she decided to wait. And that's what was confirmed. There was a ring chromosome 18. So sometimes the testing is picking up some of these things. It pays to ask questions. But yeah, you can see what's challenging about this technology. So one of the things that's important is we're seeing a decrease in the number of families pursuing diagnostic testing in utero, and so it's falling into the hands of our pediatric care teams. And so it's an important thing to know that there may be more patients needing to kind of finish up some of this workup coming to you, and coming to your clinics, your ICUs, all your places. And so that may be something that is coming up more often. And in part, even when we do counseling, even when we talk with patients, when they've had some of this cell-free testing, it's flashy, it's on buses, it's the newest test, so we must have been tested for everything, and they really haven't. And it's a tough place to be. So if a child had a diagnostic test, like an amnio with a karyotype or a microarray, we don't need to repeat that. And we just need a copy of the result and be able to look at that and confirm, yep, diagnostic testing was done. If diagnostic testing was done and was normal, but we still have residual concerns of a genetic condition, then we need a genetics consultation, and inpatient, outpatient, and situation is child dependent. Any questions?
Do you guys know if most pediatricians are routinely offering amniocentesis in this testing, or do patients have to advocate for that?
So OBs, they are, yeah. So OBs, midwives, because it's the standard, they need to offer this testing. And so they need to offer screening or diagnostic testing. And so it's one of those first few visits talking about, are you concerned about this? Would you want some testing? This is how it can look. You may be paying for it out of pocket. What does that look like for you? But they are having that conversation. It's one of the things the American College of Obstetrics and Gynecology says you need to offer this to your patients. So it's not something patients need to ask for, but sometimes, things are on buses and they come in and they go, I want that flashy test on the bus with the happy lady. I want to be the happy lady, and I also want to know if I'm having a boy or a girl super soon because I want to have a party on this day because my mom will be in town. There's reasons, and you go, oh, well, let's back up. Is that the best test for you, and why, and what are your risk factors? And so you're trying to have a conversation, but it's in the background of commercial pressure. And people are like, but the happy lady, I want the test the happy lady had. So those are some of the things that offices are dealing with.
I'm sure this varies from patient to patient, but from an uncomplicated pregnancy standpoint, how often are you seeing these women prior to delivery?
Just a normal pregnancy?
Well, I mean, if they're coming in, they have a prenatal diagnosis and they're coming in to be further evaluated by you guys. How many times, ideally, before that baby was born, would you like to see them? Because I'm hearing that their clinic visits are long. They may be coming from a far distance, so I'm just curious.
It depends on the diagnosis. So if we're talking about cardiology, those patients are seen about, depending on the diagnosis, a fetal arrhythmia or a baby in high drops is going to be seen sooner. But if it's just, say, tetralogy, a flow, we'll go with that one. We see them about every 6 weeks, usually 3 to 4 times a pregnancy, depending on when their initial visit was. We like to see patients around after their anatomy scan, which is usually 20 weeks. So a lot of these patients were seen around 20 to 24 weeks, but sometimes we see as early as 18. So depending on when we started their care, will kind of helps with our interval, but about 3 to 4 times more. If it's a fetal arrhythmia, we could be seeing them weekly. If mom has lupus, we could be seeing them every 2 weeks. Or if their prior child had heart blocks, we'll see them weekly. To try to see if there's something we can intervene on, because that is a diagnosis we can intervene on. For a surgical patient, sometimes we see them once. They come into us, it's gastroschisis. We'll see them once. We'll do their diagnostic testing. They'll meet with pediatric surgeons. We'll kind of get them plugged in to Seattle Children's. We'll get them plugged in for a tour. So if you consider a tour an appointment, but really in our clinic for appointments, a lot of our surgical patients will be seen one time because we try to do everything on one day for them because they're coming from so far. So it really just depends on the diagnosis, but
Thanks for the presentation. I'm just going to piggyback on the first question that was asked, with it being offered, and you did mention like things are covered, things are not covered. Let's say a family wants it, but they are not able to pay. Are there options for that, or are they just... I'm just curious, like, what a provider would do in that scenario, and are they given information if they can't afford? And this is kind of like a financial question, so I'm not sure if there's an answer to it. But
it's kind of a controversial answer, actually, because companies are competing with each other, and they want the business, right? And so, ethical or not, some of them do offer, oh, well, out of pocket, we'll only charge you $400. But what are they charging your insurance company? $3,000, $5,000? It gets ethically very sticky because you do have companies that come out with that information. Some of them are just eating the cost. Others have inflated it on another end. And how does that work? So yes, there's been some options. But yeah, it's very tricky. It's hard to know, do I work with a lab that does something like that? Is that ethical? Is that ethical billing? It's a tricky process.
can I ask a question? So a serum screen or one of the screening tests, most insurance companies that is
Yeah,
covered?
most insurance companies will cover the screening test. Cell-free DNA, because of recent recommendations, if you're over 35, they're more likely to cover that. But if you're low risk, 25, roll in wanting a cell-free DNA, your insurance company may say, nah. Now, there have been recent tests looking at, for low-risk women, how this rolls out, how it works. And it does a decent job. It does a good job. But your insurance company can still reasonably say, yeah, we have other things you can do. We're going to cover those other things. We know they're pretty good. If you want that, you have to pay for it.
Thank you for the presentation and for talking about the institutional billing versus the out-of-pocket max. I think that's a really important thing for all of us to know. But also, my question is, because we're going to be sharing a lot of patients, what is your guys' experience or feedback that you've gotten from providers here or your families about the biggest barriers in that transition and the gaps in care and where you think we could focus?
I don't get a lot of feedback necessarily from patients about gaps in care. I think it's more our observations of what we think. So,
I think a lot of it's maybe them retaining the information, and so I think sometimes nurses or providers are like, oh, well, they got all this information prenatally, so they should just already understand it. They should know all these resources. And, you know, we've heard from our families, they're in shock. And when this baby is born, sometimes it doesn't matter. They were like, oh yeah, they did talk to us about that. And it slowly starts to come back. But just sometimes starting with them, like, so I know you probably got this information prenatally, but let's see where you stand today and just go through your full orientation with them. Go through, this is where everything is in the NICU or the CICU. I know you've already seen it all. I know you know where the showers are. They took you there. They took you to go do these things. But just kind of starting from, let's pretend like they don't know anything. And then if they're like, oh yeah, it's coming back to me now, I've got it. Or, oh yeah, that's what that doctor said was going to happen. And just kind of reminding them, remember when Dr. Lewin said this was going to happen at this day of life? And they're like, oh yeah. And just trying to help them remember that, because a lot of them, they've told us, like, it is just those first couple days is just kind of a blur, and just trying to help them kind of piggyback on what they did learn. But I don't think they've ever necessarily to come back to say, I think our biggest challenge is people who don't come right after birth. So some of our brain anomalies, some of our brain anomalies are seen 1 to 2 weeks after delivery for like an unsedated MRI. They don't need to come to Children's, but that's actually been a really big scheduling and logistics nightmare for our families, because people are like, well, we don't have a referral, even though Dr. Doherty and Dr. Tully said I needed this. And they're like, how do I get seen? Like, what do I need to do? And they're calling us for help because they're meeting barriers when they're trying to make outpatient appointments. So it's really our struggle is with families who didn't get admitted right away and are trying to be seen and to do the plan of care we set in place, but they're meeting resistance from our outpatient clinics because they're saying, well, we don't have this information and we don't know who you are. And people also, if they looked in the mom's chart, would see, oh yeah, this was the recommendation. The family is really on board. So I don't know if that necessarily answered your question, but
and I think some families, if they don't have an immediate follow-up, if it's in 3 to 6 months, the recommendation, if their pediatrician's looking at their baby and going, your baby looks great, like, they don't want to think about what they heard from us. And so we do sometimes lose people to follow up even though they've been told things. I think from the genetics portion, I think remembering that women have a lot of tests in pregnancy. They don't know what they're giving their blood up for half the time. And so I think, again, fresh starts. I think some scenarios I've been in that are hard is a lab saying, oh, you have this deletion, and mom learning a lot about it and not doing diagnostic testing. And it turns out it's actually shifted down and it's a whole different ballgame. And that was a very hard conversation to have, because this one had a nice, cute name, and this one just had letters and numbers and things. So as far as follow-up from the team, I think, refreshing, restarting. Some things I think about, like for some of our families that do the cord blood testing, would it be really nice for them to meet a genetic counselor while they're still in the hospital, just got done with their heart surgery, the baby's doing pretty good? Maybe. Or some of those are great candidates to meet afterwards. So it's hard to say. It's hard to say what would be better or improve. But I think, we don't get a lot from families back.
We review all the charts after a baby is born. We do QI on all of our patients, so I think that's how we notice a lot of these things sometimes where issues did pop up. So I read frequently in charts like, oh, we need to do this genetic test on this baby, and I'm reading it and I'm like, we already did it and I already have the results in my hand, but they didn't know to look prenatally to find those records, or they didn't go to try to obtain where that cord blood was done. And so a lot of times if we can catch it soon enough, we will get those results and just send it on over to the attending that we saw that wrote that note. But if a patient was seen prenatally, you can always be that first look to be like, oh yeah, they did have this. So when you're in rounds and they're like, oh, well, we're suspicious for this. And you're like, but they already actually did have diagnostic testing and this is what it came back. And you can help kind of give some of that information. Because that can
save. We try and scan it into the mom's medical record and have that there under outside records.
And then sometimes if we can see it soon enough, we'll fax it to medical records to have them put it into baby's chart as well, just to be an extra double check. So we do try to catch that because we don't want them to get another bill for another test. We don't want a baby to get poked again for all of that blood unnecessarily. So that is something we notice when we're reviewing all of our cases postnatally to see, did we get it right? How are they doing? That's something we frequently find.
Yeah, but our lab genetic counselors catch it too. So
Yeah.
there's been a big reduction in that, and so
And some of the
just
forecast
a
list.
lot of hard work's gone into that and reducing that, and it's pretty impressive what we've been able to do. Virtually every institution has the same issue when I brought this up with other genetic counselors, and so in some ways that's reassuring, like, oh, we're all in the same boat. Like, it's just really hard to make that mom to baby transition for everybody and have that information pass over. They could have a little bracelet with all their information that you could just scan. That would be so nice.
I was just thinking with the transition to Epic, is there a way to link mother's chart with the baby?
We had some,
Repeat the question.
That's a great question. So she was asking if, with our transition to Epic, if there could possibly be a way of linking the mom and the baby's records, or maybe the forecast tool. We did meet with someone from Epic on Monday because they were like, oh, we almost completely left out maternal and OB records on Epic, and then we found out you guys exist. We're like, good, glad you found us. So we did make that mention that it would be really nice if there was some way of connecting and linking forward, because it's a lot to expect of our providers to be able to know, to go. Moms and babies often have different last names. It's not quite as simple as that. And to look back, it's a trick. So if that was there and able to have a quick matchup, that could probably help a lot.
I have one last question. It sounds like you have a liaison for each patient. It sounds like it's great continuity of care and that helps facilitate the whole process of, being pregnant to having the baby. And part of that is like the discharge planning. Is care coordination involved from the beginning when they're seeing your clinic, or is it just when they come here?
So we don't have any care coordinators, so it falls on nursing, genetic counselor, and our social worker to kind of do that piece as well and to kind of do that care coordination. But we do not have care coordinators in our clinic. And our social worker has been trying, because our social worker is a new role in our clinic, to pass off to the ICU social workers. So hopefully that there is some good handoff, but we haven't necessarily had like nurse handoffs or genetic counselor handoffs or anything like that to help with that transition. But yes, no care coordinators, just us.
Awesome. Any other questions?
All right, well, thanks for having us here. We
Yeah,
really
thanks
appreciate
for joining
it.
us.